we are shifting to the next speaker, Dr. Tamer Sherbini. He is going to present evidence-based use of glucocorticoids in thyroid practice.
في البداية أحب أحيي حضراتكم على وجودكم في ظروف الكورونا الصعبة. أحب أحيي التشير بيرسونز أساتذتي في وحدة الاندوكرينولوجي، وأحب أشكر أستاذ دكتور فهمي إمارة وأستاذ دكتور طلعت عبد العاطي على دعوتي لحضور الفيري ساينتفك ايفنت. أنا هكلم حضراتكم النهاردة على تجميعة للإيفيدنس بيزد يوز أوف glucocorticoids in thyroid practice. في certain indications هم actually 6 كلهم هنشوفهم مع حضراتكم، كلهم based على guidelines يعني evidence based recommendations. The first would be Amiodarone induced thyrotoxicosis, and we are going to quote the recommendations of European Thyroid Association. So we know that Amiodarone is a potent antiarrhythmic drug. It has limited uses, but it's still we resort to Amiodarone. It has very high content of iodine. A single tablet of Amiodarone may contain more than 50 times the recommended daily allowance of iodine. So if iodine deficiency can harm the thyroid, excess iodine can also harm the thyroid, and that is why it may cause either hypothyroidism or hyperthyroidism. We are going to comment on Amiodarone-induced thyrotoxicosis. We have 3 types of which. The first type, the type 1 Amiodarone-induced thyrotoxicosis, is a sort of iodine-induced hyperthyroidism. So it is excessive production of thyroid hormones coming from the thyroid due to an underlying cause. So this patient has already an underlying nodular disease or underlying Graves' disease, and so you give the thyroid this excess iodine, and so it starts to develop severe thyroid hormone secretion. While type 2 Amiodarone-induced thyrotoxicosis is a sort of destructive thyroiditis. So in these patients, the thyroid is originally or essentially normal, but you give this much of iodine, it may actually cause thyroiditis, a sort of destruction and release of preformed thyroid hormones. Amiodarone-induced thyrotoxicosis type 2 is the most prevalent in iodine-sufficient areas. Egypt is an iodine-sufficient area. And in general, it is the most frequent encounter type of Amiodarone-induced thyrotoxicosis. And then some patients will present with a mixed or indefinite type where we have both features of both types. So in order to differentiate Amiodarone-induced thyrotoxicosis type 1 from type 2, actually we are going to focus on the type 2 because this is the one that we use glucocorticoids for management. And so if you don't have an underlying thyroid abnormality, think of type 2. If you perform Doppler ultrasound and you find no hypervascularity, think of type 2. If the radioactive iodine uptake is suppressed, think of type 2. Usually antibodies are negative. It would require a long duration for this type to develop, maybe up to 30 months. Here, the resolution maybe more or less is the rule. Patients may develop hypothyroidism after thyrotoxicosis, and finally, the main line of treatment would be glucocorticoids. And so you are going to diagnose type 2 if there is no goiter, no hypervascularity, suppressed radioactive iodine uptake, no autoantibodies, and no traps. And so it is the recommendation of the European Thyroid Association that glucocorticoids would be the first line of treatment in cases of Amiodarone-induced thyrotoxicosis type 2 in moderate to severe cases, because mild cases may go without treatment only if the cardiologist insisted on treatment, and so you would cooperate with the cardiologist to treat this patient. And so the proposed dose would be 30 milligrams of prednisolone, and you are going to down titrate the patient against euthyroidism. So if you reach the euthyroidism, you are going to down titrate until you completely withdraw the glucocorticoids. And of course, more severe patients would require longer duration of treatment. And then we have the mixed type. Because the mixed type has an element of underlying thyroiditis, he may actually benefit from giving the glucocorticoids. And so actually this is not a recommendation, this is a suggestion by the European Thyroid Association. If you diagnose your patient as mixed or indefinite type, then you have one of 2 approaches. The first approach is to start with antithyroid drugs. You evaluate your patient in 4 to 6 weeks. If the patient does not reach euthyroidism, then you would add glucocorticoids. And this is the first approach. The second approach is to start antithyroid drugs and glucocorticoids right from the start. The flow for this approach is that you expose your patient, who is a cardiac patient, to the hazards, cardiovascular hazards of glucocorticoids, but it is still an approach. And then we are going to review the Graves' Orbitopathy. The sources of the recommendation come from what we call European Group on Graves' Orbitopathy. It is short for EUGOGO. It has 2 versions of their guidelines. The second one was published in 2016, and we are going to quote the recommendations. We can use glucocorticoids either for prophylaxis against Graves' Orbitopathy or for the treatment of Graves' Orbitopathy. Starting first with the prophylaxis. So radioiodine confers a small but significant risk of developing or exacerbating Graves' Orbitopathy. That's why if the patient has high risk of developing Graves' Orbitopathy, you are going to cover him with prophylaxis of glucocorticoids. That is, patients who are smokers, patients who have high free thyroid hormones, patients who have high TRAPS, TSH receptor antibodies, and patients with recent onset hyperthyroidism. We have 2 regimens for prophylaxis. The original one was a high dose, relatively high dose, 0.3 to 0.5 milligrams of prednisone per kg per day for a period of 3 months. Later, another study introduced another smaller dose, only 0.2 milligrams per kg per day, and for a much smaller time, only 6 weeks instead of 3 months, and actually it gave the same result. So you are free to give either the high dose or the low dose regimen for a shorter period. And that's why this recommendation came with a high level of evidence, recommendation 1. The second use would be for the treatment of Graves' Orbitopathy. This is how we go for Graves' Orbitopathy. If the patient has mild Graves' Orbitopathy, we don't use glucocorticoids unless the patient has markedly impaired quality of life. This is not a common scenario. If the patient has moderate to severe and active disease, we go for IV glucocorticoids as first choice. If the patient is presenting with site-threatening dysthyroid optic neuropathy, then we give IV glucocorticoids. We assess after 2 weeks. We may resort to compression, decompression surgery, and if the patient is still active, we are going to give IV glucocorticoids. So why is this guidelines insisting on IV glucocorticoids? Because IV glucocorticoids compared to oral is more effective. So it was effective 80% versus only 50% for the oral, and it was better tolerated for the adverse side effects, was only 40% against 80% for the oral. So it is more safe and it is more effective. So if you give a high single dose, that's to say more than 0.5 grams of methylprednisolone, or if you give a cumulative dose of more than 8 grams of methylprednisolone, this is going to double the risk of adverse events. And that is why, and this includes cardiovascular, cerebrovascular, and hepatic side effects. And that is why, for safety reasons, it is recommended not to use a single dose that is higher than 0.75. Do not use a cumulative dose that is higher than 8 grams, and do not use consecutive day therapy. And you have to assess liver enzymes, markers of viral hepatitis, fasting plasma glucose, and hepatic ultrasound before initiating this treatment. So, according to this assessment, contraindications to the use of glucocorticoids induce viral hepatitis, severe hepatic dysfunction, severe cardiovascular morbidity, uncontrolled diabetes, uncontrolled hypertension, and psychiatric illness. And if the patient is fit to receive IV glucocorticoids, you are going to monitor this patient. So you should monitor liver enzymes, glucose, and blood pressure on a monthly basis. You are going to give proton pump inhibitors to guard against the development of peptic ulcer. And if the patient has high risk of developing osteoporosis, you are going to give bone prophylaxis. So the recommendation is to give IV glucocorticoids, not exceeding a cumulative dose of 8 grams. So we actually have 2 dose regimens. The first dose regimen is an intermediate dosing regimen where you give a cumulative dose of 4.5 grams of methylprednisolone. This is given on a weekly dose. The first 6 weeks you give 0.5 grams of methylprednisolone, and the second 2 weeks you give only 0.25 grams of methylprednisolone, a cumulative dose of 4.5. And this should be applicable for most of the patients of moderate to severe Graves' orbitopathy. Only the severest cases of mild to severe Graves' orbitopathy that you are going to use a high dose regimen. And the high dose regimen consists of 12 weekly doses. For the first 6 weeks, you are going to give 0.75. And for the second 6 weeks, you are going to give 0.5, a cumulative dose of 7.5 grams of methylprednisolone. If the patient was given IV glucocorticoids and he showed no response, one of the available responses for this patient is to repeat the IV glucocorticoids therapy, provided that you don't exceed cumulative doses of 8 grams. If the patient presents with site-threatening Graves' orbitopathy, that's to say dysthyroid optic neuropathy, then you are going to give very high doses of IV glucocorticoids. So you are going to give from 0.5 to 1 gram of methylprednisolone, either on a daily basis for 3 days or on consecutive days. And then you are going to assess in 2 weeks. If there is no response, you are going to perform decompression surgery, and then you are going to evaluate your patient. If the patient is still active, then you are going to give him IV glucocorticoids. And actually, this very high doses of IV glucocorticoids on a daily basis proved to save the sight of up to 40% of such patients. And then the third indication for glucocorticoids is the use in Mexedema coma. Actually, we recently, only in the last 5 years, we have 2 sets of diagnostic criteria for Mexedema coma. I'm going to present the simplest of which. This scoring system depends on a Glaxo coma scale, TSH being more or less than 30, low free T4, hypothermia, bradycardia, or the presence or absence of a precipitating event. And according to the cumulative score, you are going to give a likely diagnosis or an unlikely diagnosis of Mexedema coma. And these are the specifications of diagnostic criteria. The American Thyroid Association says that empiric glucocorticoids should be employed as the initial therapy for Mexedema coma using intravenous glucocorticoids at stress doses. And this was a strong recommendation. And they also recommended, if possible, to ideally acquire a baseline level of cortisol before initiating the IV glucocorticoids. The Latin American Thyroid Society almost gave the same recommendation, so empirical glucocorticoids are used, give 100 milligrams every 8 hours of hydrocortisone for patients with Mexedema coma. Is adrenal insufficiency that common in patients with hypothyroidism? For this study, they sought to study the adrenal reserve in patients with newly diagnosed hypothyroidism, and they found that up to 18% of newly diagnosed hypothyroid patients at the time of presentation do have adrenal insufficiency. More than 50% of these patients are severely hypothyroid patients. They have explained this, but the prolonged period of hypothyroidism actually impairs the ability of the body to secrete glucocorticoids, and they also prove this by the fact that 80% of these patients actually restored a normal adrenal reserve just by correcting the hypothyroidism. So apart from the fact that maybe autoimmune hypothyroidism and autoimmune adrenalitis may coexist, and so the patient is at risk of having adrenal insufficiency, hypothyroidism itself impairs the ability of the body to secrete glucocorticoids, and that is why it is a must to replace. And then we go to the thyroid storm. The recommendations is coming from the American Thyroid Association, the Brazilian Society of Endocrinology and Metabolism, and the Japanese Endocrine Society. So we have 2 sets of diagnostic criteria for thyroid storm. The older one is known as Burch and Wartofsky criteria. It is a scoring system, again, with the collective score either giving likely or unlikely diagnosis of thyroid storm. And then we have the most recent one, and this was introduced in 2016 by the Japan Endocrine Society. Again, it depends on the presence or absence of thyrotoxicosis, CNS manifestations, fever, tachycardia or atrial fibrillation, congestive heart failure, gastrointestinal or hepatic dysfunction. And again, we have a set of diagnostic criteria to either say this is definite or indefinite thyroid storm. After establishing the diagnosis, the Japan Endocrine Society recommends that you should give glucocorticoids, 300 milligrams per day of hydrocortisone, or alternatively 8 milligrams of dexamethasone per day. This was a strong recommendation, moderate quality of evidence. Again, the Brazilian Society of Endocrinology and Metabolism almost said the same recommendation, and they also gave the same dosing regimen. Hydrocortisone 8 milligrams every 8 hours, or dexamethasone 2 milligrams every 6 hours. Why? The rationale for giving glucocorticoids in such a patient. First, there would be relative adrenal insufficiency that is caused by the hypermetabolic state in a thyroid storm. And the second is that very high doses of glucocorticoids actually impair number 1, secretion, and number 2, conversion of thyroid hormones. And so by giving this high dose of glucocorticoids, you are actually treating adrenal insufficiency and ameliorating the hyperthyroidism. The American Thyroid Association gave the same recommendations, the same dosing regimen, and the same rationale for use. Finally, you should monitor for potential side effects of glucocorticoids, and before eventually stopping the glucocorticoids, you have to make sure that the hypothalamic pituitary adrenal axis is restored back to normal. And then we have the very common presentation of subacute thyroiditis. Subacute thyroiditis is sort of maybe viral thyroiditis. It has a seasonal presentation. Usually it presents here in Egypt between August and December. Up till now, I have seen 2 or 3 cases myself, one of which presenting as pyrexia of unknown origin. The diagnostic criteria for this patient, for a patient with subacute thyroiditis, would be pain or tenderness in the thyroid, elevated CRB or elevated ESR, thyrotoxicosis, that is to say high free T4 and suppressed TSH, and an ultrasound showing hypoechogenicity that corresponds to the area of pain. And accordingly, if the all 4 criteria are met, so this patient is diagnosed with subacute thyroiditis. If the patient meets the clinical criteria and any of the 2 of the lab or imaging criteria, then maybe this patient is presenting with subacute thyroiditis. You have to exclude bleeding in a thyroid cyst. You have to exclude acute suppurative thyroiditis, and you have to exclude anaplastic carcinoma. Actually, there's no consensus on what is the perfect glucocorticoid regimen for such a patient, but what I'm going to present you is, in my belief, the most evidence-based regimen. So this is a low dose and short period regimen where you give 15 milligrams of prednisolone for 2 weeks and then down titrate to 10 for 2 weeks and then down titrate for 5 for 2 weeks, a total period of 6 weeks of treatment. Why do I consider this evidence-based? Because the study that gave this protocol included more than 200 patients, 219 to be specific. They all met the diagnostic criteria of subacute thyroiditis. In 6 weeks, 50% have resolved without recurrence, and in 8 weeks, 80% resolved without recurrence. So the clinicians were looking for, number 1, the presence of pain, and number 2, the value of CRB at each step of down titration. So if the patient is experiencing pain, or if the patient is still having elevated CRB, they did not down titrate. They extended the same dose for another 2 weeks, and then they go for the next step and so. So in 80%, in only 8 weeks, they responded completely without recurrence. So this is a very effective regimen. Finally, we find that OB and gynecologists, they use glucocorticoids excessively in patients with autoimmune thyroid disease. And so that's why I have found these 2 recommendations. The first recommendation by the American Thyroid Association that recommends against the use of glucocorticoids. It is not recommended in autoantibody positive euthyroid women undergoing assisted reproductive techniques with a moderate quality of evidence. And again, the Society of Obstetrics and Gynecologists of Canada, just this year, they said that we recommend against the use of glucocorticoid steroids to treat women with just positive antithyroid antibodies. So to summarize, only 6 indications exist to use the glucocorticoids in thyroid practice. In type 2 and mixed amiodarone-induced thyrotoxicosis, prophylaxis against Graves' Orbitopathy, treatment of Graves' Orbitopathy in the use of Mexedema coma, thyroid storm, subacute thyroiditis, and do not use glucocorticoids for fertility or pregnancy outcomes in patients with merely just anti-thyroid antibodies. And thank you all for this.